Hi everyone. On occasion of World's Hospice and Palliative Care Day, which falls every second week of October, today myself, Dr. Anusha Karumuri, interventional pain physician, would like to introduce what exactly is the palliative care, and in front of me, Dr. Anjana Surath ma'am, who is the head of palliative care unit at KIMS, would like to give insights where exactly the palliative should start. Hi madam.
Hello, good morning. Actually, palliative care is nothing different from the general medicine, and it is if you define it, then we usually include the patient and the patient's caregivers. So it's a team of patients and patients' caregivers, and it is addressed to the quality of life of both members of the team, the
Yes,
patient and their caregivers. And how do you improve the quality of life? You have to address the symptoms so that the patients are comfortable. You have to address the symptoms which are physical, mental, psychological, social, and sometimes spiritual also.
Yes ma'am.
So you have, unless you address all that, especially at the end of life. Now, end of life can be few months, few year, or a year, or few weeks, or few days. So during that time, if you address their symptoms, the mixture of symptoms, then you can make them comfortable and improve the quality of life.
So palliative care, where do you think it is indicated, ma'am?
Well, sometimes palliative care is started as soon as any chronic illness is noted, and from day one, people include palliative care after, if they are getting admitted to the hospital, to manage their symptoms and make them comfortable. So it's sometimes it is along with the acute care, sometimes it is after the acute cares are over. So it is there is no hard and fast rule. Palliative care can be given in ICUs also, and it's always good because ICU patients do very well if palliative care is included in their day-to-day care.
Yes, so it's a long-term illness both for the caregiver and for the patient. It's a big stress. So palliative care can address both the things.
Absolutely, absolutely. Because sometimes the caregivers have some concerns which are not medical.
Yes.
So they don't know who to ask and where to find out. So since the palliative care department includes a team, a team of nurses, a team of social workers, a team of pharmacists or physiotherapists,
Yes.
and sometimes volunteers.
Yes.
So since there are so many members, each concern can be addressed by a different member. So they feel comfortable going through the journey of sickness.
Last time when we were discussing about a patient who is confused about where to end the treatment, where to go for a aggressive ventilation, where to stop the palliative, where to start the
palliative disease guided treatments.
Yes. So it was very much you have guided them in a proper way, ma'am, because I've been seeing, as a pain physician, we are talking about a lot of cancer patients.
Yes.
And they are very much confused.
Yes.
When to stop their main therapies and when to give a end of life care. What insights can you give it for all the patients?
So as I was saying about palliative care being given during the acute illness, what we say is at that time palliative care can be given by the primary physicians. You don't have to include a palliative care physician or the team.
Okay.
But if we train the primary physicians in palliative care, or if they are aware of it, then it can be done early.
Okay.
Right? So then they know when the time has come to hand over the patient to the palliative care department. Now, if they don't understand that themselves, they cannot guide the patient. So normally we say when any chronic illness, it may be hypertension, it may be diabetes, it may be say kidney disease, it may be heart disease, lung, or say hepatic,
Okay.
And cancer, of course, is one of the most common diseases that is using the help of palliative
Yes.
care. So in all those conditions, when we have run out of treatment for the organ directed problems, so that there is no more option left for treating the disease, primary disease.
Okay.
There is no, then you don't have to tell the patient, we have run out of treatment and I can't do anything. Most of the time this is what they hear, and this is most disheartening for the patients. So at that time, if you say that yes, we cannot do the disease guided treatment, but we will not abandon you. You can be under the care of palliative care physician, and they will see to it that your life is comfortable, and that whatever disease related symptoms are there, they will address that.
Okay.
So that the person doesn't feel that let down.
Yes.
That having gone to a doctor for years together and suddenly they say that now you go on, you are on own.
Yes.
That's the time they are going to suffer.
Correct.
So if they know that they have some other area where they can be taken care, they will happily go there.
Okay.
So that is where the palliative care will enter.
Okay.
Usually that is where we
So
would
ma'am,
say.
like when I saw a patient who had this big ascites, means there was water in the abdomen, and he was having severe pain. He was diagnosed as CA liver, cancer liver. So they were in very much confused state, ma'am, where to stay and what treatment they should take. So how can you guide as a palliative care once the primary consultant got aware about palliative care is there,
Yes.
and once they hand it over, how will you guide them, ma'am?
So it starts, we see such patients in OPDs usually. So what do we do there is that we go into detailed history of them.
Okay.
It's not only disease history. As I said, we address the social background, we address the psychosocial and also emotional, spiritual, everything.
Yes.
So sometimes you find that social difficulties are very
High.
Yeah, very high.
Very high.
And that creates some kind of fear in patient and anxiety in the caregivers. So when combined that, patients are really jittery as to what's going to happen now, right? And every day coming to hospital for those symptoms becomes difficult, because somebody has to bring the patient, someone has to spend the time with the patient when they are in the hospital. If they get admitted for 1 or 2 days, it is a financial problem burden also.
Correct.
So in that case, what we do is we listen to all this.
Okay.
And depending on that, plus depending upon the background and the requirement, first I have to assess the requirement. Sometimes what happens nowadays, it's very common, people get worried on seeing something they can, see every day, rather than, feeling it. So palliative care addresses symptoms. Palliative care ignores signs.
Okay.
Okay, signs that are visible or not visible. We ignore the signs.
Okay.
We stress upon the symptoms.
Okay. So
We,
ascites means
yes.
you will.
Also, we do not treat the reports. Somebody comes with a report, there is 3 liters of fluid. I will not drain it.
Okay.
I will wait
Yes.
till the patient becomes discomfort.
Symptomatic.
Yes, he becomes symptomatic. Then I'll say, okay, now we can do it.
Okay.
Now we'll relieve you of
Once
your
he's
distress.
breathlessness, then you will advise.
Yes, so
for
if
the
he is in distress, yes, we will address it. If it is not causing any problem,
Okay.
then we ignore it.
Okay.
So in such cases, we tell them, don't worry, the fluid is going to come back. You are explaining each and everything, what they should expect in
Preparedness.
Yes, we have to prepare them for the really end of life. Though we call it end of life, but still they may survive 6 months. So we tell them in those next 6 months, it's going to be a recurring problem. It's going to come back. Even if I drain today, it's going to come back. Secondly, even if it comes back, don't worry about it. It's not disturbing you. It is nothing that is going to interfere. The day you become, symptomatic, then you can go to the doctor. We tell them it's a simple procedure. You go to any doctor nearby, so that they don't have to waste time in commuting, and the financial this thing also is taken away from the whole thing. So one, they become more confident about their own body. Two, they know that it is possible that we will, supposing somebody's father, then he feels that I will not be disturbing my kids, during the daytime, because hospitals work during the daytime, and then they have to give up their work and then they have to take. So it becomes easy. I can also go in the evening to a nearby place and get the water removed. So that confidence and that satisfaction is there. So it is, once you have to tell the diagnosis, clearly the diagnosis, the prognosis, the future, and what exactly is being done. Is it really, are we dealing with the disease, or are we just
giving the comfort?
That's not even comfort if you don't remove most of the time people don't even remove the water fully. So it fills up faster. So in cancer patients, we usually remove whatever is possible. We know it is end of life, it doesn't matter. Let the patient be comfortable. Today we are not thinking of tomorrow. So our this thing. And also, yes, I am coming to that. Pain, usually it may sometimes it is associated with pain. So that has to be dealt. And you have to explain the reason for pain and the reason for water. Is it the same? Is it different?
Yes.
And are these two things going to lead to the death very fast or not? Okay. Yes. So unless you explain everything, they are worrying about so many things.
Yes.
So once you have addressed each and every symptoms, they feel much better. Now with the ascites, they may have constipation, they may not be eating properly. Yes. So unless you ask those things,
correct,
and they will focus only on what they can see.
Yes.
Or if you don't bring it up, that it is going to happen in future, the feeding will come down. So it is
holistic. You are taking care
view
of the feeds, you are taking care of the constipations issues, ascites and the pain. Ma'am, what about the pain? You have taken a lot of experience before in other hospitals, cancer hospitals and chronic illnesses. You have dealt with lot of medications.
Yes.
It may be a tablet, syrup form and IV forms.
Right. So in palliative care, the first dictum we follow is, if the gut is working, use the gut.
Yes.
We don't go for injectables, infusions, if person is taking orally. Unless if they are vomiting or there is a block or whatever it is, then perhaps we will go further. So the first thing is oral tablets. Then second thing is that we say whatever is available to the patient. So now if the patient is living in a village, I cannot prescribe narcotics and say okay because you cannot give asthma. You don't know how long the person is going to require, how much to give, and you can't ask them to come again and again to the city to get this. So you use whatever is available nearby. That is the most important. Third thing is that at the end of life, we don't want them to suffer. That we are looking at, but we don't want them to spend too much of money. So normally cancer patients and all, I am not talking about benign pains. Cancer patients, the chronic pains of patients at the end of life, we normally do not prescribe, say, expensive. Now the narcotic patches are available and all, which are very expensive and difficult to handle in our country because of the summer, and they don't stick, and we don't want them to. So preferably we do use
balancing
things. So those are the certain rules that we follow as such. Now there are patients who have pains, say visceral pains and all that, and they are otherwise, say they have only, I would talk about cancer, bone metastasis. They live for a longer time. We know that they live for a longer time. There we will do we can send them for interventions. Their interventions we recommend. Also, if it is one organ pain which is localized, nothing else, then we say okay, interventions are going to help.
Like as you said, when you tried on some medications and all that, finally you have called me to involve into some intervention
Yes,
procedures.
yes.
So I have done few of the intervention like celiac plexus block.
Yeah.
You burn the nerves in and around the where the tumor is getting
Right,
supplied.
right.
So these are all palliative care procedures
Yes.
which
So
can
these
help
are
patients
yes,
from pain.
yes. So there are number of patients who will require interventions. At the end of life, I would say around the 6 weeks, those where we expect the patient to be not be surviving beyond 6 weeks, there we will not do interventions. The others can have, as I said, isolated organs, isolated areas. Yes, we will definitely refer them. But if they have multiple pains, then again we depend on the orals.
Yes.
So we will not recommend that.
So the same patient we have taken to a completely palliative care, and during the end of life, few other patients also they expressed that the main thing they couldn't handle people suffering from the pain and discomfort.
Yes.
So finally, I've seen you starting some IV infusions in the ward.
Yes, yes.
And that was a peaceful. Maybe I can say
Right.
that was comforting both the patient as well as the attenders.
Yes, absolutely. So it all depends upon how much comfort we can give and what we are expecting under the circumstances to go wrong in that certain families, certain background, okay. And say there is a child, definitely everybody is suffering. If it is an old person, say 90 or something, we know that people will come to terms with the death. Now, death is something we do not talk about. Palliative care, we talk about death very often. We talk to the patients also about their death. And we do try to find out what they want to, do, or if they know that they are not going to survive longer. So
Yes.
what are their wishes and how they want to be dealt with, where do they want to die. In a number of cases we do that. We are not, I won't say in India we are open and we will ask directly, it doesn't happen,
No,
but
as,
we
you
have to
mentioned,
judge.
There was one child, and I can see the difference in the family when you have entered. The very next day they had a small treat with the family. They
Yes.
had some cupcakes and a small treat.
Right.
Where you said now there is no restriction in giving a specific food.
Yes.
So that made a lot of change.
Right, absolutely.
Yeah.
So if we say in ICUs and all, we usually forget about patients' wishes, families' wishes, and the patients are there because perhaps we have not counseled them enough to say, okay, this patient perhaps is not going to make it. So let them be happy, take them home, and you let them be
With the
their
family,
normal self
yes.
with the families and all that. In ICU, the biggest hurdle is that while counseling, we do not say that what we are doing, say ventilation, say infusions, is only to keep the body, the other parts of body functioning. But the disease part is not being taken care per se. Okay? If person is dying of say kidney disease and we are keeping that person for say breathlessness in the ICU, we don't say that we are not going to treat the kidney. It is difficult.
Where palliative care should be.
So if
started.
if it is introduced at that time, it will be clear to everyone because we talk very openly about these things. So we tell them, if you want the happiness of your dear one, then you can do these things. We are not going to abandon. Even if you go home, we will have people coming home to help you.
Yes.
Because most of the hospitals and palliative care units have home care teams.
Okay.
We don't have it here, but it is a requirement because sick patients cannot come to hospital all the time. We have to tell them that beyond this, even if the patient makes, gets out of this ICU this time, he will be back in say another week or 10 days because the illness is still there, persisting. So if we explain those things, then
Possibility of readmissions will be less.
yes, the people don't bring the patient to hospital again and again. If you tell a person that you see his brain is not functioning and his body is functioning and he is going to survive long, you cannot keep him in the ICU for that long. So what do you want? Can you make any arrangements at home? We'll help you making arrangements at home and take care of the patient at home. So
regularly,
then they
I've been seeing you in follow-up calls, ma'am. The people who are in the villages and all that, they give even video calls to you,
yes,
and you guide them.
Yes.
And I felt that the confidence which you are creating among the caregivers and the patients is huge.
So as I said that we give them right on day one that we enter, we say no, we are not going to abandon you. So wherever you are, you can get back to us. We will guide you what to do. Number of times what happens is, say patients in the middle of night, they are brought to the hospital because we have not warned them that this patient is going to become more dyspneic. So if the patient is really breathing hard, they don't realize that this is pre-death. So if you have to warn. So when we do video calls and all, we see the patient, we know that say a patient may survive 24 hours, 48 hours or something. We tell them don't go to the hospital, stay where you are, take help of a doctor nearby, and they can at least give the sedation to the patient for the benefit of the caregivers.
Yes.
So we have to look after them, and in today's day when the technology is so popular and everybody has smartphones, so it's not difficult to reaching anybody. For them to reach us and for us to reach them is so easy. So why not do what you can do?
Yes.
So our aim is to comfort and comfort. So that's how you can achieve it. So
thank you,
we are open.
Thanks for lovely insights on palliative care. And as once again we want to just be a part of as a multidisciplinary team, where in a palliative care, a primary consultant, palliative care physician, and a pain physician with palliative trained nurses all can form a group and take care of the end of life.
Right.
Thank you, ma'am.
Thank you so much.